Hello, everybody. Do you hear me properly? My name is Jolanta Bilinska. I would like to start today our webinar organized by World Patient Alliance. It is a regional webinar for Euro region, and my request from organizer is that we unmute ourselves because when we will have voice, we start our presentation. We have soon very important day. We have World Patient Safety Day, and it will happen on 17 September 2021. That's why I invited very important people to say more about safe care for mother, for newborn, and about safety medication, and also about patient rights around the Euro region. So I will start to present you very briefly myself. So as you know, I am a founding director, board director of World Patient Alliance, and I am also a leading patient advocate. So I joined Patient for Patient Safety group many years ago, and in 2006 I established Patient Safety Foundation in Poland. So our main goal is to promote safety measure in healthcare service, but also involve patient in the process of treatment. Every day I work as a director of development and social communication and City Medical Center, Dr. Jonscher in Łódź, but I also have lectures at Caesarean Academy in Kalisz. What is the mission, vision, and vision of our organization? So our mission is to be the global voice of patient working towards patient empowerment and engagement, and we want that patients should be in the center of healthcare, and we want to do it around the world. So our vision is that all patients will have access to safe, high quality and affordable healthcare everywhere in the world. On the map, we are in many countries. We are a young organization. We act more than 1 year, and now we have 318 patient groups around in 106 countries, and we represent all disease areas. So as you see, we are in many countries in PAHO regions, so they are both America, we are in Afro, in Africa, we are in Euro in many countries, but we are also in CRO and also in the region where is Australia, Indonesia. So our board of directors, they are chair-elect. Chair is from the US, and he represents Global Colon Cancer Association. Chair-elect is Hussein Jafri from Alzheimer Pakistan organization. Secretary is Penny Cohen, and I am a treasurer. And we have also two other board of the director of the board, Carla Ruiz de Castilla. She is from Latin America, and Regina Namota Kamoga. She is from Africa. She represents Community Health and Information Network. We decided it is important for the organization to have some principles which are very important for patient and patient groups. So what is very important? Important is access to healthcare. Every patient should have access to healthcare, and it includes timely, effective, affordable, optimal, and innovative treatment. As you know, in the pandemic time, it will be in the presentation of our Minister of Patient Rights, Minister Chmielowicz presentation, that that not every patient had this access to healthcare during pandemia. Another point which is very important is patient-centered healthcare. So patient and healthcare provider must work in partnership. What does it mean? Does ensure the patient's individual specific health needs, patient desired health outcomes are very important to have a communication in this issue, so that the patient physically, emotionally, socially, and in economic aspect is understandable by healthcare provider. Financial hardship we also did as one of main points, because patients should have health coverage options that provide them with healthcare while protecting them from financial hardship. Patients should be also empowered, so they should be supported, empowered. They should express their needs, concern. They should discuss with the health provider, with nurses, with medical staff. They should have an opportunity to have a voice in decision making of their treatments. Before, many years before, it was very difficult to convince a doctor that a patient is very valuable, because he knows if he takes a medicine and feels not good, cannot take care of the children, cannot be involved in the treatment process, then the success of the treatment is also not very good. So that's why empowering patients who are empowered, they work better in communication with the doctors. Important in principle is also patient safety, quality. So all patients should be provided with treatment that are safe, high quality, and appropriately monitored. What does it mean? Even in my country, it happens before that the devices for diagnosis were destroyed or work not properly, and they damage patient health. It was once a very severe accident. Patient women were diagnosed and after using the wrong device, they were burnt after the treatment. So it was very unhappy accident. Patients should also have education and information. So we should provide patients with many options, many platforms which gives the right comprehensive, relevant, simple information, including patient background. So every patient should understand what the doctor says, what the nurse advise. The patient should have all information they are needed for his disease. Patients should also partner and collaborate with stakeholders to have, as I mentioned before, access to safe, quality, and affordable healthcare. Patients should be engaged, and of course, we cannot have any discrimination. When WHO noticed that it is so important, patient safety. You know, before 2002, nobody mentioned it. First time, World Health Assembly in 2002 mentioned urging member states to pay the closest possible attention to patient safety. You know, this is a photo of a small room, but usually during World Health Assembly, there is a big room. They are representatives of 193 countries. They are coming stakeholders, policymakers, Minister of Health, Deputy Minister of Health. They are there is like spread of information to the whole world. That's why World Health Organization is so important. If they plan to implement things, even simple, I joined the WHO initiatives when they started with hand hygiene. So before WHO implemented hand hygiene, believe me, in many countries, people didn't care about the proper hand hygiene. So I think every challenge made by WHO has a progress and has a very big influence for other countries and for simply every citizen. In 2004, WHO did a patient safety program, and it aims to coordinate, disseminate, and accelerate improvements in patient safety worldwide. I was in the group, I think 2006. They invited patient advocates, WHO invited to Geneva, and I met first time in my life people so committed towards patient issues. First time I had patient safety in many ways. So I noticed it is excellent example to work together. So here is some information about the 74 World Health Assembly and a global patient safety action plan. In this plan, WHO member states agreed to implement this plan to concrete actions to eliminate harm in healthcare. It means the patient, families, patient organization must be actively involved in the plan execution, monitoring, and evaluating of the action plan at all levels, including local, national, and international levels. So we are close to our main subject of today. So safe maternal and newborn care, and our slogan is up now for safe and respectful childbirth. Every day, and the statistic done by World Health Organization, 810 women lose their lives. 6,700 newborns lose their lives, and stillbirth occurs 5,400. It happens every day. Very sad information. Most of these lives can be saved through the provision of safe care. Very briefly, I will tell you the key messages which are prepared by people from WHO, and these messages we will hear today from our experts, from professors, WHO people, and from all who are invited to our webinar. Women in pregnancy and around the time of childbirth. So we need to speak to our health worker about how you can reduce safety risk during pregnancy and around the time of childbirth. What we should do: attend all appointments during pregnancy and after childbirth for every mother and baby. We should be actively as a mother involved in our own care and care of our baby. We should communicate openly with a healthcare team, and we should feel free to ask any questions, any concepts we have about ourselves and our baby. And we should have support from a birth companion on our choice as we wish. And we should prepare mentally and physically for our childbirth if we become a mother. So it is first message for mother, for pregnant women. We also should involve our spouses, partners, families, and communities. They should support us during pregnancy and around the time of childbirth. So we should speak up for the rights about respectful care. We should follow safety precautions for COVID-19. And we should also be involved in community initiatives which support mothers, newborn, and health workers. So it means every future mother should play an active role and work with policymakers to establish safer maternal and newborn services. What should do health workers? So they strive to make childbirth a positive experience for all women and newborns by providing safe and quality care. And they should build trust, engage, and empower women in decision-making during the childbirth. They should also apply safety measures during pregnancy and in the period postnatal, and where is a surgical safety, blood safety, radiation safety, medical safety devices, sanitation, infection prevention. So it all should be speak up to supervise or colleague if we have any concern about the safety of childbirth or if a mother or baby is mistreated. And what is the role of healthcare leaders and facility managers? So they should create an enabling environment for safe and respectful maternal and newborn care. So we should invest in health worker safety, well-being, capacity, and supportive supervision as a priority for safety in healthcare. They should also establish a safety culture. This is very important that we speak up about safety concern as a basis for system improvement. We also should promote an environment for childbirth that involves women in shared decision-making, maintaining their dignity, privacy, and confidentiality, and preventing mistreatment. And we also should establish adequate infrastructure, including water and electricity, and provided sufficient supplies for sanitation and infection prevention and control. Policymakers and program managers, so they should prioritize safety in maternal and newborn services and act now for safer healthcare system. So they should invest in health system. They should build a competent and sufficient health workforce. They should support it by a safe and enabling work environment. And they should also establish mechanisms to engage women, families, communities, health professional, association, and civil society to establish safer maternal and newborn health services. And what is important is reporting and learning system to guide improvement in this maternal care. So now is the role to present our first speaker. It is Professor Krzysztof Czajkowski. He is the head of the second department of obstetrics and gynecology, Warsaw Medical University, Poland. He has a vast experience in the field of obstetrics gynecology and has served for more than 35 years in this specialization. The Department of Obstetrics and Gynecology, Warsaw Medical University, consists of 8 wards, 156 beds, and 18 neonatal beds. Every year, around 7,000 women are hospitalized, including 3,500 deliveries per year, and around 42,000 are treated at the outpatient clinic. Dr. Czajkowski has also remained the Deputy Dean for Faculty of Medicine, University of Warsaw from 2016 to 2019. In addition, he is also serving as the President of Warsaw Gynecological Society and member of the board of Polish Gynecological Society. Dr. Czajkowski has also remained President of the Polish Society of Perinatal Medicine, consultant in the field of perinatology for Mazovian district and national consultant in the field of obstetrics and gynecology. I am very happy that Professor today had time for us to present the actual state of care for mother and children, and I hope he will also have time to answer to question at the end of our webinar. Please, Professor, the floor is yours. Thank you.
Thank you very much. Hello, everyone. I would like to present you some data about the maternity care in Poland. At first, I want to introduce my country, Poland. We are the ninth country in Europe, and we have beautiful mountains on the south. They are near 3,000 meters high, and beautiful seaside of Baltic in the north. The country is divided for the 16 parts, and we call those parts voivodes. So the fertility rate in Poland is not very high. As you can see, it's changed during the last 20 years, but of course there is too small number of deliveries just to keep the number of citizens on the same level. Last 2 years, the fertility rate was 1.38. And we have some regulations which affects the model of maternity care in Poland. At first, of course, it's a state law which has been changed last year very dramatically. But we have some regulations of the Ministry of Health, Polish Gynecological and Obstetrical Society recommendations, of course, the system of education, knowledge, and experience of the staff. We have some very specific, in my opinion, expectations from our women, from our patients, and I will the regulation of the Ministry of Health. It was changed in the beginning of 2019, and this document is the most important document of the maternity care in Poland, and every doctor should work with this document. And this document contains the following chapters: the scope of preventive services and activities in the field of health promotion, as well as diagnostic tests, which were numbered in every week of pregnancy, and medical consultations for pregnant women, the identification of risk factors for perinatal complication, antenatal education for women, antenatal care plan and delivery plan, proceeding during childbirth, some data about how to relieve of labor pain, the medical treatment at the beginning of labor and its 4 periods, how to care the newborn baby with special attention for the lactation, and care and management in the puerperium, and this document is going to help us in some difficult situation. For example, when the woman delivers a death child on the child with some malformations. And the second are recommendation of our society. Please, the next slide. Of course, they are similar to the other recommendations. There are a number of recommendations for the medical management in physiology and pathology, and they are modified every few years. The next is education, knowledge, and experience of the staff. Next. So we have a special program for specialization for the young doctors. We call them residents, and they are paid by the government. This program lasts in 5 years, completed with the tests and oral exam. Of course, there is a list of current textbooks, which is renewed every year. There is a minimum required number of the procedures and all things that should be made during the specialization. We have a new law in Poland, and from this year the program is going to be modified every year. You know that Poland is a country in Europe in which the number of systemic and a significant proportion of our patients expect a pregnancy to be terminated by cyst, which is near to the 50%. They want to have a separate delivery room. It's available in near 80% of the hospitals. They want to have the presence of a loved one or husband during the childbirth, and it's possible in most of the hospitals. It was a short period in the epidemic time in 2019 that we closed the delivery rooms for the other persons, but now it's open. Our women wanted usually to have a epidural anesthesia. We have a small problem with this. Kind of anesthesia should be offered in the 3rd level of hospitals, but we are fighting with our Ministry of Health to offer this anesthesia in all hospitals. And the rooming in is in the most hospitals in Poland. We have in Poland, women have 1 year time after delivery to stay at home, and it can be partially carried by the child of the father. Next slide. The availability of the staff of the service. We have 346 maternity hospitals or wards. Most of them they are on the 1st level, but the 3 they are on the 3rd level. We have a little problem with the obstetricians and gynecologists. In Poland, there are near 7,000 specialists in this field, but the meal day age is more than 60. Some data, a new data, because data till the 2015 they are available in Eurostat publications. So the this number in the years is going down. It's a difference between 2017 and 2020. It's around 50,000 of deliveries less. The next slide, please. And I want to show you the data with the presentation of JPG groups. As you can see, the N01 is a normal delivery, but NO9 and 11 and 13 is severe pathology in pregnancy. As you can see, the severe pathology is about 16–18%, and it doesn't change in the last 5 years. It's on the same level. Age of the women in labor. So there are many countries in the world when women deliver very early, when they are teenagers. In Poland, it's not so often. In the last 5 years, the percentage of the women who are in age less than 18 slowed down from 0.7 to 0.45%, and the number of women who delivered after 40 is slowly growing up. The mean age of the first delivery in Poland is about some other data. So the percentage of vaginal deliveries with or without episiotomy. As you can see, the number of deliveries without episiotomy is going up. In the last year, it was about 51.9%. But at the same time, the number of perinatal injuries a little bit grow up to the 4.7%. The mean number of the curettage after delivery was nearly of the same level all the time. And the pregnancies which are induced deliveries is a little bit growing up during the last 3 years. As you can see, it's a slide from Eurostat. Poland is one of the countries with the very high number of the C-sections. Please, and we are on the 4th place from the end. And the number of C-sections in last years is around 44%, but we hope that during in the few years it will a little bit will be slower, and the proportion between the planned and emergency C-section is about 50%. Of course, for the obstetrician, the number of the planned C-section in Poland is very high because it should be about 20–30%. The next slide, please. And the reason I try to explain you the reasons of such high number. I think at first they are the previous recommendation of PTGIP, which provided for the concept of women after one C-section for the vaginal delivery. It was modified in 2019, but at this time, 90% of women after one C-section, they choose another section. And nowadays, because they cannot choose the way of the delivery, many women receive a certificate from the psychiatrist indicated a caesarean section of tocophobia. I think that in Poland we have the epidemic of tocophobia, which is quite different than in other countries. And in Poland, similar to, for example, Great Britain, obstetricians are the most frequently sued group of doctors. It explains why the doctors sometimes make a decision for the C-section when the indications are not so strict. And perinatal mortality, I think we did a very great work from the 1980 to the 2019. The next, the death of the newborn is going down during last 10 years, and of course, if somebody can ask about the impact of epidemic COVID on the delivery number and pregnancy number, as you can see, the number of delivery is going to be lower in the end of the 2020. The number of the deaths from it's the brown line from the in Poland is going to be higher, I think, due to the epidemic period. But nowadays we have a low level of the COVID, and I hope we have a stabilization of this data. Thank you for your attention.
Thank you. Thank you very much for very, very good presentation. I am sure we will have more questions to Professor Krzysztof Czajkowski, but as I told at the beginning, all questions we decided to move at the end of all presentation. Now I will present our next speaker. It should be Minister Bartłomiej Chmielowiec, Patient Rights Ombudsman. Instead of him, in our meeting will be Madam Jolanta Bilinska. She is a Deputy Director of Department of Social Dialogue and Communication at Office of the Patient Ombudsman. I will share with you the most important steps, what is doing Ombudsman, what is his duty, occupation, why we have this important office, and how it helps patients in our country, but it should be a model for other countries too. So the Patient Rights Ombudsman, the Patient Rights Ombudsman was established to protect the patient's rights. Patient rights are so important and so crucial for everyone. That's why this office competencies of Patient Rights Ombudsman are set out in Act of 6 November 2008 on Patient Rights and Patient Ombudsman. The Patient Rights Ombudsman reports directly to Prime Minister. This Act of 6 November, Act of 6 November 2008 on Patient Rights Ombudsman has some specificities, and these are patient rights. These are rules regarding access to medical documentation. So everybody in Poland knows it is so popular now that our documentation, our medical records, this belongs to us, the patients. It was not as easy even a few years ago. The other rule is obligation of operators providing health services related to patient rights and mode of for appointing, removing, and the powers of patient ombudsman. And we also have proceedings in case of practice infringing collective patient rights. Another act, what is the main object to an interest of minister is rules and procedure for determining compensation and redress for medical events. You see the Patient Advisory Office, the Patient Rights Ombudsman performs his task with help of the Patient Ombudsman Office. And the task of the Patient Ombudsman is conducting of proceedings in case of practices infringing collective rights of patients or individual patients. There is also performing activities in the civil cases referred. and developing and submitting to the Council of Ministers draft of acts relating to the protection of patient rights. The minister is also applying to competent organs for legislative or of the issuance or amendment of legislation for the protection of patient rights, and cooperation with public authorities in order to ensure that patients fulfill their rights, in particular with minister responsible for health. We should also mention that providing the competent public authorities, organization, institution, and self-government of medical professions with assessment and proposal to ensure effective protection of patient rights. All is about patient rights, about also cooperation with NGOs, organizations, social, professional organizations, with the statutory objectives of which include the protection of patient rights, and also analysis of patient complaints in order to identify the risks and areas of healthcare. Which action do ombudsmen according to patient issue? So, example, applying to competent organs. So this office, patient rights office, also applying to competent organs like to Minister of Finance regarding the allocation of funds in the draft budget act to finance the construction of the medical register system, or the Minister Chmielowiec took an action to the Minister of Health and Minister of National Education to introduce a new subject in schools, health knowledge. Or another example, proposals to ensure effective protection of patient rights. Council for developing a recommendation on fetal therapy. This futile medical care is the continuous provision of medical care on treatment to a patient when there is no reasonable hope of a cure or benefit. Another step or an action of the patient ombudsman. So proposals to ensure effective protection of patient rights. Council for preventing discrimination against people suffering from obesity. So, as you know, in every Euro country, there is a problem that obesity patients sometimes cannot find a proper bed in the hospital or in outpatient clinic. So that's why there are many complaints, and there is also now an example to take care of rights of these patients. Another example, publications and educational programs, like a project Right of a Clinical Trial Participant. As you know, there are many patient representatives. We teach our patients what is the clinical trials, what are the rights of our patient participants, that they can lead the clinical trials in every moment. The consent form should be signed after proper discussion with the doctor. So this project is, my heart is with this project, because the right for a clinical trial participant is very educational for our patients. Another project, Patient Rights Ombudsman, spokesman for Polish seniors. Seniors were always hidden part of our society. Now seniors have rights. Seniors are very important part of our society. So that's why this project is also very crucial and very on time. Another example, analysis of complaints about the healthcare system and legislation. So the Council of Experts at the Office of the Patient Ombudsman, the Patient Organization Council can deal together how to improve our healthcare system, our legislation. Another project, impact of health inequalities on patient rights. So the health inequalities can be defined as differences in health status or in the distribution of health determinants between different population groups. So I presented now some actions and they are very important almost for all parts of our society. Advisor of patient rights on the psychiatric hospital. So the structure of the Office of the Patient Rights Ombudsman includes patient rights advisor of the psychiatric hospital, who performs his duties in psychiatric institutions throughout the country. The task of ombudsman in psychiatric hospital is to protect the rights of patients who receive health services provided provided during hospitalization. Also, very, very important role. Ombudsman for patient rights of the psychiatric hospital provides people with mental disorders help in asserting their rights in the methods related to admission, treatment, condition of stay, and discharge from a psychiatric hospital. Also, very, very important role, important thing. Another thing is explain and provide assistance in explaining oral, written complaints of these people, cooperate with their families, legal representatives, legal and or actual guardians. Last point, initiate and conduct educational activity in the field of patient rights in psychiatric hospital. So ombudsman considers cases reported by patients as well as their legal representatives, legal and actual guardians. They can also act at their own discretion. So this is about the advisory role of patient rights on the psychiatric hospital. Now I will take some more examples what did the ombudsman office during this difficult time during the pandemic. So patient rights to health services during pandemic. The main problem reported by patients included complaints about the functioning of primary health care, no possibility to make a personal visit in the outpatient clinic. It was not only in Poland, it was general in Europe, in the whole world, a difficult time. Nobody was just so easy to do the telemedicine. So at first, people had really bad access to hospital, to outpatient clinic, so on. Another issue was too long waiting time for specialist services. During the pandemic, some appointments were cancelled with no any date set. Another objection concerning the comprehensiveness and thoroughness of the services provided, so including telephone consultation. And it was a limited access to diagnostic despite having a referral. Some entities, mainly hospital, refuses to perform imaging tests, ultrasounds, claiming that they perform them only on hospitalized patients, not from outpatient clinic. Another problem, it was ethics of healthcare professional. So sometimes patients reported that inappropriate behavior was towards the patient. And numerous denials of orthodontic treatment for children and adolescents during the epidemic. Only emergency situations were solved immediately. And last point, it was a difficult situation in nursing homes, healthcare centers, and psychiatric hospitals, which consisted, among others, in the lack of personal protective equipment for residents, patients, and staff. So if we have in group the main problems reported by patients, we can say it was extending waiting time for access to medical records. It was refusal to send medical records by post, electronic means communication. Nobody wanted to take a call because they said, oh, it is not permitted, and also not sending email. So it was a really big problem to have a medical records at that time. Another problem reported by patients, it was making access to medical records conditional on personal submission of the application. And another one is the closing healthcare entities, which results in lack of access to medical records also. And the last point, it was requesting that medical records be collected personally by the patient or the authorized person. What in this pandemic time was not easy. So the main problem also the continuation is to not allowing loved ones to be present during the provision of health services in both outpatient and inpatient treatment due to epidemic situation. Still in many hospitals, even in my hospital, it is prohibited to visit friends, to visit family, only on the special condition. If somebody is very long in the hospital, the department officer, manager can suggest, okay, this person can have a visit, but it is not common. Another complaint to ombudsman were about the conditions of dying in dignity. It was no opportunity to say goodbye to loved ones. And complaints were about the condition of waiting for the provision of health services. It was not possibility to enter a clinic without the consent of clinic.
How are you gonna do this inside?
Services in tents outside hospitals. And it was not allowing a companion to be present during childbirth. So it still is not easy, but I heard in this many hospitals slowly the doors are open for husbands, for close family to be at at newborn babies. It was also refusal of personal contact with loved ones during hospitalization. So the ombudsman has, among other things, appealed to healthcare providers to consider relaxing the restriction on patient rights in situations where there is no suspicion of COVID-19. I can also give one example of my hospital. We have not also a department with surgery, etc., but we also have a house, a part of our hospital for long-term care for elder people, for senior people. And these people were very, very upset not being in touch with the family. They are not good in technology, so they don't have mobile, they don't use Skype and other social media. So that's why for some time patients could have a visit from family, friends, if they come and there is social distance and they are vaccinated, so there is no problem anymore with visits. Another issue, a problem reported by patients to ombudsman was decision of the management of some psychiatric hospitals not to hand over parcels for patients from their loved ones. Most of them contain personal hygiene products and essential items necessary during the patient's stay on the ward. So also very good point. Which was referred to psychiatry hospitals and is solved now. It was also limiting of the ability of parents to provide additional care to their children. It also changed nowadays. And not allowing the family to visit a terminal patient. to say last goodbye. I know this is nowadays changing many hospitals. This is for Polish participants, so we can call Friday to Monday from 8 to 6 o'clock. Office is on the Patient Ombudsman in Młynarska 46. So this is the telephone number, and I will tell you, I forget at the beginning to say more words about our Minister Bartłomiej Chmielowiec, Patient Rights Ombudsman. I will do it now. He's an ombudsman since 2017. Mr. Bartłomiej Chmielowiec has a long experience as the Chief Specialist of Legal Department at Financial Ombudsman Office, formerly the Insurance Ombudsman. He mainly deals with legal analysis and consideration of cases of victims of economic insurance, drafting legal acts, drawing up motions to the Supreme Court to adopt resolution aimed at resolving discrepancies in the case law of common court. And he also took an active part in parliamentary legislative work. Mr. Chmielowiec is a graduate of the Faculty of Law and Administration from Maria Skłodowska-Curie University in Lublin. He has also completed postgraduate studies in accounting and the Faculty of Management and Computer Science and the University of Economics. Moreover, he is also completed his Master of Business Administration MBA. He has been a legal advisor at District Chamber of Legal Advisors in Warsaw. Mr. Chmielowiec has also worked at the Prime Minister Office, and he has served as the Counselor of the Head of the Chancellery of the Prime Minister. Furthermore, he has also served as the coordinator of the Economic Affairs team in the Department of the Standing Committee of the Council of Ministers. He is author of numerous scientific and popular science publications in the fields of civil law, compensation, and insurance law. But as I mentioned at the beginning, today it is with us Jolanta Bilinska. He is Deputy Director of Department of Social Dialogue and Communication at Office of the Patient Ombudsman. Anyone who will have a question to Madam Bilinska, I will please all send me, or at the last point we will ask Madam Bilinska, and she will answer to this question. In front of us is our next speaker. Our next speaker is Madam Alhana Mai. She is a head of prescribing and therapeutics for Scottish government. As head of prescribing and therapeutics for Scottish government, and previously Deputy Chief Pharmaceutical Officer for Scotland, Alhana is responsible for coordinating delivery of government work programs, advising ministers on quality, safety, and effectiveness of medicine. Recently, she has been working as part of the government team on the COVID response. She is responsible for development of national polypharmacy clinical guidance, patient app, and shared decision-making tools. Alhana has recently been awarded European Union funding for implementation of polypharmacy as an adherence program across 3 countries for people with multimorbidities, sympathy, stimulating innovation in the management of polypharmacy and adherence through the years, and less successfully delivery of European-funded project Sympathy, stimulating innovation in the management of polypharmacy and adherence in the elderly. Lead work for WHO on polypharmacy, and is an expert advisor and consultant for WHO on patient safety. For International Foundation of Integrated Care, she coordinates the special interest group on appropriate polypharmacy and adherence and is European Union Coordinator for work on active and healthy aging, on polypharmacy and adherence to treatment. As Quality and Safety Fellow, she runs clinics and has received health improvement funding to develop a street outreach to improve homeless people management of multiple morbidities and medicine with first sector partners. She holds a leadership master from Harvard Napier and is associate professor at Napier University and honorary senior lecturer at Robert Gordon and Strathclyde University. We welcome very much Alpana, and the floor is yours, Alpana. Thank you.
Thank you very much, Jolanta, for the kind invitation from the group. And hello and good afternoon. And it's here, and thank you for having me to talk to you today. So I'm going to just spend the next 10-15 minutes talking to you about a patient-centered digital approach to address polypharmacy and high-risk medicines. And these can affect anybody at any stages of their life. And obviously we can think about it today with a bit of the context on the population that we're making the focus of World Patient Safety Day of mothers and newborns. So we know that multimorbidity is common globally, and that as people get older, that they're going to live with more than one long-term condition. And I know that that's something that you as an organisation are very passionate about. And this is really important when we think about it's not very old that people start to have 2 long-term illnesses, and in areas of deprivation this might happen much sooner, much earlier, and as a result people tend to take lots of medicines for these multiple morbidities. The important thing here is that when we think about treatment for an individual, we shouldn't think about age, but we should think about how functional an individual is and what their ability is. And when we often look at disease guidance doesn't differentiate between the old woman on the left-hand side and the gentleman sitting on the sofa. And so when we think about mothers or people who are thinking about pregnancy as well, that could be another category. So when we're thinking about treatment options and using guidances for the management of multimorbidities or long-term conditions, we need to think about how we adapt that to the individual in front of us. For example, if we were to give a blood pressure tablet to both these individuals, the chances are that the lady on the left, it might make her lightheaded and dizzy, and she may not be able to do her daily activities, whereas actually the gentleman on the right hand side needs to do a lot to manage his blood pressure. And obviously for mothers, we need to think about treatment and think about the risk benefits. So often it's about using clinical judgment when we're making these decisions. So why is it that people end up on lots of medicines? So we all know an aunt or an uncle that's recommended some medicines to us, or doctors prescribe the medicines, but it can also be that traditional and herbal medicines have an impact, so that this means that people can often end up taking many medicines that have an effect on each other without actually realizing the consequences. And when we do have long-term illnesses, sometimes people can be quite frail, and frailty often increases the number of medicines that people are taking, but also when people are frail, the body maybe doesn't deal with the medicines as effectively. So things such as thinking about kidney and liver function of an individual will have an impact, because this affects how the body deals with the medicines that they're given. So I wanted to share with you, Jolanta asked me to just really share with you the actual number of medicines that many people can take. And this is one area that we've been putting a lot of focus on in the work that we've been doing in Scotland and across Europe. And if you look at this chart, you can see that many people take many medicines, and actually these are not the number of tablets, these are the number of medicines. So imagine that you're taking 12, 13 medicines, but actually you're not just taking 12, 13 different medicines. You may take these 2 or 3 times a day, and it produces a huge treatment burden. And often people will say to me that sometimes that they're burdened by the medicines that they have to take and the number that they have to take, and try and plan their day around the medicines, and it can have a huge impact on people's lifestyle. And if people don't understand how to adjust treatments, they may stop themselves from going out. For example, if somebody's being asked to take a water tablet, and if they don't know how to adjust the timing of that, it might mean that their social life and their social well-being is hugely compromised as well. So we need to think about the person as a whole when we're thinking about the medicines that an individual might. So it's not always a bad thing to take many medicines. For some individuals, it can be appropriate to take many medications, particularly if all of those medicines are going to give them the benefit that we want them to. However, where it becomes a problem is if a patient is asked to take a medicine that they're not happy to take, or they're not going to get the benefits from, if they're not happy to be able to take them for that required length of time or that frequency. Now, we also know that many people, when they take medicines, when they take 4 or more medicines, they are unable to take them as prescribed. Now, sometimes this is known as non-adherence, but sometimes it's not intentional. So people do it by mistake. And sometimes that unintentional non-adherence can cause quite a lot of harm. We know that quite a large proportion of asthma deaths are caused because people don't take the medicines as prescribed, and the same for diabetes and heart disease. And if we think about this dosette box that this person has prepared here, you can see that somebody is trying to organize their medicines to try and remember to take them. But if you look very carefully, all they've used this for is to decant the tablets. So sometimes patients do different things in order to try and help themselves manage how to take their medicines. And it's about making sure that there's enough support to make sure that we manage these effectively. So is a polypill the answer? And I would say that there will be a scenario where we will end up with a polypill, that we can just even print the polypills off a 3D printer. But first of all, we need to make sure that that polypill has the right tablets for the individual, so that quite often, sometimes people end up taking another tablet to counteract the side effect of a tablet they've been given. For example, somebody who's been given an anti-inflammatory medication for their hip pain or their joint pain may then develop indigestion and need an indigestion mixture to manage that. It's important that we use technology and the advantages that we'll have, but we need to make sure that we are just giving an individual the right medicines. And people need to be able to therefore ask the questions: what's this medicine for? What benefit am I going to get from it? And are there any possible harms from taking it? And one of the situations that you find when people, particularly mothers, when they don't take medicines or when they're planning a pregnancy, is when they don't understand the risks and benefits, particularly with medicines such as for asthma medication. And people can stop taking steroid inhalers, for example, because of worries that it might do harm to the unborn baby. Why is this important? Well, it's important because as people take more medicines, they're likely to take a medicine that we would refer to as a high-risk medicine. So these are medicines that, when they're taken inappropriately, are more likely to cause harm. So one of the examples I gave you was medicines for blood pressure, for example, or an anti-inflammatory. The other ones can be opioid medications, so for painkillers. And we know that across Europe, if we look at the data and the research, that about 11% of all hospital admissions happen because of harm caused by medicines. And if we extrapolated that information across Europe, 8.6 million admissions every year in Europe happen, an unplanned admission due to the harmful effects of medication. And 50% of these hospital admissions are actually preventable. And 70% of these do occur in older people, but you can see that 30% will still occur in the younger individuals. And you can see that it's a huge cost to global health. So one of the approaches that we've had is to take a person-centered approach where the patient or the person is in the middle. And when we're thinking about prescribing medication, or if a medication is appropriate for them, we first of all start off by thinking, what matters to the individual? What's important to them to be able to do? And thinking about, can they address this through lifestyle? What do they want to achieve on a day-to-day basis? So for example, the older lady that I showed you earlier, it might be important to her that she can not feel unsteady on her feet so that she can keep walking and keep getting out and about. So it's really important to think what's important to the individual. Once we've got that, we need to think, have we got the right medication for the condition? And we need to think about stopping any unnecessary treatment. So it's really important that we, as clinicians, provide the space for patients to share with us if they're taking any medicines that they've bought for themselves, any traditional medicines that could have an impact, or actually if they start experiencing side effects, maybe we need to change the original treatment. If we are using medicine, we need to make sure that there's adequate monitoring so that we know that the medicines are being effective. Excuse me a minute. And we need to make sure that patients are able to share if they're experiencing any harmful effects from the medication. And in many countries, patients will still pay for medication, so we need to make sure that we use the most cost-effective medication. And then finally, back to the patient again, we need to agree and share the plan with the patient so that the patient or the carer agrees with what the healthcare professional has talked about with them, and they come to that decision together. In order to help patients make these decisions and to be active partners in their care, what we've produced is this polypharmacy app that's available to everyone, so anybody can download it wherever you are in the world. And the important thing for this audience will be that you, once you click onto it, you choose the option of patients and carers. If you can find out information on the medicines that they are. So if you're being prescribed a new medicine, you can look it up and find out all about the medicines. And that might be quite important for people who are taking many medicines, which again is polypharmacy, or if they're taking a medicine that's likely to have some side effects, and it will list the information within there. And what it also has in here is shared decision making. So once you've got the information about a medication, how do you decide as a patient whether you're going to benefit from the medicine or not? And this is a tool that the healthcare professional can sit and provide the patient. And this has been developed with patients, which addresses issues around health literacy and is in language that's enabling for patients to share. So using the faces to illustrate the risks and benefits of treatment. And you'll see the shared decision-making tools come up again, please. And so you can pick a particular medicine that you're interested in, and if you move to there, you'll see that the smiley faces tell you that the grey faces represent the number of people in the survey group, and the green one will tell you how many people have benefited from the medicine. So if you just here, you can see for the number of people here that one person benefits, and that's known. That tells you how many people need to take the medicines in order for one to benefit. And there's some information here that then provides the patients or their carers information about the medicines and the side effects, so people can make those decisions and understand if they do take the medicine, something happens to them, it's not maybe their condition getting worse, it's actually maybe an impact of the medication. The other bit is that quite often if patients are taking many medicines, they need somewhere to safely have a list, so that if they see many different healthcare professionals, they can share with them what their list of medicines is, so that when a healthcare professional goes to prescribe a new treatment, we can make sure that the two medicines don't have an impact on each other. Or if they get discharged from hospital or going into a care home, again, we can make that the case as well. In the case of a mother, they could hold their list on here so that they could keep a list of the medicines that they were taking. So here you can see, you click on the My Medicines, you can add your medicines, and then you can click the medicine that you want, and then you can add it to your list. So it's your way of holding your own list of medicines. Quite often what we find is that patients are prescribed treatment, but they often don't want to tell the doctor that they're not happy or they're experiencing side effects and don't necessarily take those medicines. So by having an accurate list, if you do get admitted to hospital or you see another healthcare professional, you can have that conversation with them. And one of the things that we're trying to do in Scotland as part of one of the European projects, iSympathy, as Jolanta described, it's about stimulating innovation in the management of multimorbidities, polypharmacy and adherence through the years. So right the way through the course of life, reviewing when people need to take many medicines. So that's polypharmacy. And it might be that some of those medicines are high risk. So again, those medicines that if they're not taken appropriately are the ones that are more likely to cause admission to hospital, and thinking about making sure that we pick up any misinformation or miscommunication as a person might move across different care settings, so the transitions of care. So across 3 countries, Scotland, Ireland and Northern Ireland, we're going to be doing 15,000 patient reviews where we're giving the patients an opportunity to be part of their shared decision making using that 7-step process. And we'll be collecting information on patient reported outcome measures. So one of the other things that's in the app is patient reported outcome measures. And that gives, if you want to have a look, it does give you additional information that you, even though you're not part of the study, might want to access and discuss with your healthcare provider about how your long-term condition makes you feel, or how that has an impact on you taking your medicines. For example, we know that low mood is a common symptom of long-term illness. So people don't take their treatment because they become disengaged from managing their long-term illness. And there'll be some economic assessment to try and demonstrate that it's much more economic to spend the time and the resources in order to provide patients the forum to discuss their medicines and to do that for individuals. So I hope that's given you a flavour of some of the work that we're doing, and particularly about the person-centred approach to address when an individual takes medication, and how the patient and the person can be an active partner in these conversations. And I'd be delighted to take any questions that anybody has. So thank you again.
Hello. Thank you very much to Madam Alpana for a wonderful presentation. In front of us, Dr. Mafaten Chouali. I hope I pronounced properly your name. It will be a presentation, Act Now for Respectful and Safe Childbirth through an Integrated Healthcare Service Delivery. I will very briefly say Dr. Mafaten Chouali is a Technical Officer, Hospital Quality and Patient Safety at the Health Workforce and Service Delivery Unit of the Division of Country Health Policies and System of the WHO Regional Office for Europe. She has a medical background and master's in infection prevention and control. Dr. Chouali is a certified professional in healthcare risk management, healthcare quality, and certified professional in patient safety, and board certified in infection prevention and control. We are very short with time. Please, we give the floor to Dr. Mafaten. Thank you.
Thank you, Jolanta, for the introduction. So hello, everyone. And thank you for joining us. First of all, I would like to start with thanking the World Patient Alliance for organizing this webinar and for the invitation. And I want to thank each and every one of you attending this presentation. It's really my pleasure to be here today talking about a subject that is very close to my heart. So the aim of this presentation is to give a quick overview about the World Patient Safety Day, and to talk about this year's theme and why it was selected by the World Health Organization. And I will talk about what can we do at the system level and a little bit at the organizational level to improve patient safety in the area selected for 2021, women and newborn safety. So the World Patient Safety Day was established, as you know, in May 2019 by the World Health Assembly by resolution WHA 72.6 on global action on patient safety. And the day is marked annually on 17 September. The aim of the day is working together towards solidarity and action to promote patient safety and increase public awareness and engagement in healthcare safety. This year, the WHO is shedding light on a priority patient safety area where actions are needed to reduce avoidable harm and improve health outcomes. As you can see in this slide, 2 million babies were stillborn every year. 810 pregnant women lose their lives daily. 6,700 newborn lose their lives every day. And these numbers were further compounded by COVID-19 pandemic, which has led to the disruption of essential health services due to breaks in supply chains, due to women's inability to access care, and the shortage of skilled healthcare professionals. So considering the significant burden of harm that women and newborns are exposed to due to unsafe care, and that most of these lives can be saved through the provision of safe care, as well as the fact that women's experiences during childbirth might be affected by issues of gender equity and violence, the team selected this safe maternal and newborn care. And our slogan this year is Act Now for Safe and Respectful Childbirth. My presentation today is going to be an optimistic presentation. And why is that? We'll see it. Well, in fact, the majority of maternal and newborn death and stillbirth are avoidable by the early detection of risk factors. And we know that the major complications actually accounting for nearly 75% of all maternal death are severe bleedings and infections, mostly after childbirth, pre-eclampsia, eclampsia, complications from delivery and unsafe abortions, and other infections or mismanaged chronic conditions. So we got to the conclusion that through the provision of safe and effective diagnostic services and the quality of care and treatment during pregnancy, childbirth, and in the first days of life, many of these deaths could be averted. So with the better access to proven intervention, we can be saving many lives. And in order to improve maternal and infant outcomes, the WHO Global Safe Strategy for Women's, Children, and Adolescents Health 2016-2030 stresses on the need to integrate the delivery of health services and life-saving interventions and commodities, and to support health workforce to provide good quality service. So we need a healthcare system that supports women have a safe delivery and a healthy infant by providing a continuous care services throughout the childbearing continuum. So we have the pre-conception services, followed by the maternity and antenatal care services, then the care services at the delivery time, to neonatal care services and postnatal care services. But many healthcare systems still have gaps in this continuum. These gaps can be either in policies, in the pathway design for patient, in knowledge, both for healthcare professionals and for the public. It can be in the quality of services delivered, and we know that there is a huge gap in communication in healthcare between levels of care and healthcare providers themselves, and even between departments at the same facility and even in the same department. And one thing that I would say about communication, as far as I am concerned, is that in healthcare, we don't have static teams that work together. Teams are going to change, you know, by the hour or by the minute, depending on what the situation is. And they all are contributing to that person's care. So it's a very complex process environment, and communication really needs to be paid attention to more than anything else, because one thing I know from my work in healthcare risk management is that the majority of sentinel events, and this is when somebody was really injured or died while receiving care, so the majority of sentinel events, exactly 2/3 of them, are related to miscommunication. When you look at the root cause analysis view, and you know, when they dig deep into what actually happened, it's that there was something wrong in communication. So all these gaps can be filled by a policy environment and a political will that create a model of care that is person-centered and integrates all the layers of care, and by the application of management service and practice at organizational and care delivery level, and by disseminating best practices and applying science and tools for patient safety. So at the strategic level, we need to plan on providing the healthcare services that are closely related to maternal and newborn care in the different layers of care, in complete integration and coordination between primary healthcare and hospitals and higher specialized centers when working on health investments and reforms. For example, providing, for example, pre-marital screening services that screen for genetic diseases as well as infectious diseases that can be offered in primary health care clinics to facilitate women's access to the service. The integration with hospitals can be by performing the complicated lab tests for these referring entities as well. We will see this in the next slide, but we can improve also the referral system between the preconception clinics and hospitals for the pregnancies at risk. Some of the enablers, according to some countries' experiences, is in providing actually premarital screening services are improving data security and confidentiality for test results to gain the trust of women and encourage them to for screening, developing screening test packages specific to the population needs, so the most common genetic conditions in that geographical area, and raising public awareness on the importance of conducting screening tests. This slide is about the preconception care services provided by some healthcare systems that can have many advantages, as we will see. These services should be known by women and available in primary healthcare to provide necessary vaccination before pregnancy, diagnose and manage chronic diseases before pregnancy, map family genetic disorders, and plan for the pregnancy, including a roadmap for supporting stopping, smoking or alcohol use, for example, and receiving the necessary dietary supplements. The preconception assessment enables caregivers to anticipate high risk and potentially complicated pregnancy, and therefore plan and coordinate for a timely management of these cases at the right level of care. So few enablers of the preconception clinics' success are raising awareness among the public about the role of these clinics and supporting specialized testing through specialized reference laboratories, and creating pathways for women with risk factors for pregnancies. For maternity and antenatal care services, the first area of improvement that we should be thinking about is to integrate hospitals and specialized centers with primary health care and pre-conception plans to assure the continuum of care for the at-risk pregnancies at the right level of care and avoid any delay in referral or any miscommunication between care providers. Then we can adopt the health interventions that should be delivered during pregnancy and delivery that are summarized actually in the WHO recommendations on maternal health, which includes the guidelines approved by the WHO Guidelines Review Committee in 2017 and the WHO recommendations on antenatal care for a positive pregnancy experience, which aims to prioritize person-centered health and well-being, and not only to the prevention of death and mortality. And few examples of interventions that can improve the quality of maternal and antenatal services are to advocate for the use of the WHO guidelines by healthcare professionals, to facilitate the referral of at-risk pregnancies by allocating, for example, case coordinators within primary healthcare centers to help manage these cases, and by raising awareness of women about the early access to maternity services. Facility level, actually, one of the tools that WHO provides to professionals in the SAFE is the SAFE childbirth checklist, and this tool has the potential to facilitate the compliance of healthcare professionals, midwives, nurses, doctors, with best practices for the delivery of evidence-based better birth at the obstetric units. This tool ensures the delivery of essential maternal and prenatal midwifery care practices that address the major causes of maternal death, intrapartum related stillbirth, and neonatal deaths. So complication from obstetric hemorrhage, infections, obstructed labor, hypertensive disorders, inadequate intrapartum care, birth asphyxia, and complications related to prematurity can be minimized. This tool also enables the caregiver to acknowledge the limitations and gaps in the currently available health service delivery unit and advocate for supplies and equipment. For neonatal care services and neonatal care services, and due to the unique vulnerability of neonates, even minor errors can lead to devastating short and long-term consequences. Missing information can lead to treatment and medical errors. That's why we need to work on improving communication between prenatal care providers and neonatal care providers. In addition, of course, of improving neonatal intensive care units availability and the coordinated access to them, and maintaining a full range of pediatric medical and surgical subspecialists and pediatric anesthesiologists to deliver the service. In addition, of course, to standardizing neonatal care services to better address health concerns and outcomes of newborns. So last but not least, for postnatal care services, we know that the first 6 to 8 weeks after birth, these weeks are very important for both mothers and newborns. That's why they need to access a range of postnatal services at the hospital, primary health care, or at home. Services such as conducting clinical examinations for mothers and newborns, postnatal education for mothers, postpartum mental health, social and domestic support for mothers' issues, vaccinations for babies, all should be known and accessible by mothers closer to their homes through primary health care or clinics or in hospitals. And to enable that, we can develop postnatal care guidelines that facilitate the coordination of services based on mother and child conditions. We can also provide postnatal education programs for mothers about vaccination, nutrition, breastfeeding, psychological support, and follow-ups. And finally, we can raise public awareness about and promote the use of postnatal care. Since 2017, the WHO Regional Office for Europe supports member states in implementing the European Action Plan for Sexual and Reproductive Health towards achieving the 2030 Agenda for Sustainable Development in Europe, leaving no one behind. This action plan covers maternal and child health from pre-conception screening till postnatal care to mothers and newborns. The Act Now for Safe and Respectful Childbirth calls on all stakeholders to support and prioritize safety in maternal and newborn services in the healthcare system by creating, enhancing, improving and sustaining healthcare services that are closely related to maternal and newborn care in the different layers of care in complete integration and coordination between primary healthcare and hospitals and higher specialized centers. Then to support healthcare workers in providing respectful care to women and newborns by creating a safe environment, work environment for them, and building a safety culture throughout the healthcare organizations, and adopting, of course, incident reporting systems that allow for reporting and analyzing safety issues, and adopting evidence-based guidelines and tools proved to improve the safety of women and their babies in the point of care. So our key messages for leaders and healthcare leaders is to prioritize maternal and newborn services and act for safer healthcare system by allocating sufficient resources for access to maternal and newborn health services, building up at the same time as sustainable, ethical, and safe framework for the delivery of advanced reproductive care services. Also by building a competent and sufficient health workforce supported by a safe and enabling work environment, establishing mechanisms to engage women, families, communities, health professionals, associations, and civil society to establish safer maternal and newborn health services, and developing and implementing up-to-date guidance on safe and respectful childbirth. And of course, we don't forget establishing reporting and learning systems to guide improvement in maternal and neonatal care. So today, we all in this meeting together want to reach the unreached and ensure safe maternal and newborn care, particularly during childbirth, by adopting comprehensive policies and strategies within broader health systems strengthening efforts. So let's act now for safe and respectful childbirth. At the end of this presentation, so I want to thank you all for your attention, and I want to thank our hosts for making this meeting possible. Back to you.
My dear speakers, I would like to thank you in name of World Patient Alliance for wonderful, wonderful presentation. You can't see because you were engaged in speaking, but people reflect how much they receive information, awareness about the maternal and newborn safe care and about safe medication. And I am really, really glad to have you all at this wonderful day, how to say, we are before the World Patient Safety Day, but for many people it is a chance to be on our webinar. It is, I am really sorry, but we don't have time for a question, but question, of course, will come. So I suggest all participants can send to WPA by email all questions, and we collect them and receive the answer or from Dr. Mafaten or from Professor Tchaikovsky or from Alpana or from Ombudsman office. And then we publish it with all materials, with your presentation and also this question answer. We categorize and put on a page because we extended the time. It was so interesting, and I was so happy when I saw in chat this really good reaction. Thank you very much, and I hope we can see each other another time. We plan next year a congress in Rome, so I hope many of you can join us during this congress of WPA. It will be in person or hybrid. We will see what COVID will bring us in the future. Thank you so much.
Thank you so much.
All, and good evening for everybody. Thank you so much. Bye.
Thank you. Bye. Bye.
Ciao.
Bye. Bye.
Thank you, Jolanta.